Today, I will talk about complications after hepatic resection in terms of ICG-15 values. In Japan, at most institutes, hepatectomy procedure is selected according to ICG-15 values as shown in this slide. So in this study included 11,686 patients with ICG-15 and information of hepatectomy. They were classified into 4 groups according to ICG-15 values. So I will show you operative deaths. Purple area shows a patient who met Makuchi's criteria, and the blue area shows indicate a patient who didn't meet Makuchi's criteria. You see that in the blue area, the incidence of operative death was high. And complications of Krabbe-Dindo 3 and above were its incidence was very high when in the patient with who didn't meet Makuchi's criteria. And in intractable ascites, you see that in all hepatectomy procedures, the incidence of intractable ascites increased according to the ICG-15 values became big. Bile fissura, the incidence of bile fissura was not associated with ICG-15 values. It's associated with surgeon's technique. A surgical site infection in partial resection and thoraxectomy, its incidence increased according to ICG-15 value increased. Liver failure. In bisectionectomy, liver failure incidence increased according to ICG-15 value increased. You see that in the blue area, the incidence of liver failure was very high. That means in patient out of Makuchi's criteria, the incidence of liver failure is high. So in conclusion, ICG-15 is a good indicator for predicting operative death complications over Krabbe-Dindo 3, intractable ascites, and liver failure. Hepatic resections can be performed safely when they are indicated within Makuchi's criteria. Thank you very much.
Thank you. Questions from the floor? I have one quick question. You have mostly liver cirrhosis, I suppose. Are those results the same for absence of cirrhosis and cirrhosis?
Same.
Same. Okay. Yeah, Renato?
Thank you. A very quick question. As you know, this is very widely used in Japan, yes, and not so widely used in the rest of the world. And so my question to you, we do it, but we don't apply drastically, I would say, the ICG clearance as you are doing in Japan. And so my question is, have you done a multivariable analysis showing that this is really an independent factor? Because you show only this factor as the factor to act, to do or not to do any resection. So I'm a little bit on doubt of this. What is your comment?
You perform ICG-15 examinations at your institute, but you don't use it for selecting surgical procedure, right?
We use it as a part of the total decision, not as the only factor that may lead to yes or no for hepatic resection.
Because except for ICG-15, what do you believe for selecting surgical procedure? Albumin? Albumin level?
Yes.
But the best indicator, to my mind, ICG-15. Of course, in some patients, ICG-15 is not reliable. For example, a patient with, collateral vein, paraesophageal collateral vein, or splenorenal shunt, the value is not reliable. But in most patients, the value is reliable.
Okay.
I have a question, Eduardo de Santibáñez from Argentina. congratulations for your paper. I have a question regarding in the line of René Adam. If you have a patient with an HCC, small, 3 centimeters, but with a ICC of 12 and a portal hypertension, it has low platelet, hyperesplenism, and you can see some varices. What is the value that you give in this patient with high portal hypertension and almost a normal ICC?
Well, I do hepatectomy as usual, according to my coach's criteria, ICG 15-12.
Yes, and some
In such case,
and
okay,
some
then
ascites.
systematic subsegmentectomy I will do. No doubt.
Okay. Thank you.
Thank you.